My name's Gary Morris. I'm affiliated with the Science, Medicine, and Technology curriculum subgroup. And on behalf of them, we want to welcome you to today's session. Please, right now, take out your cell phones and either turn them off or silence them so that we don't interfere with Bruce's presentation. Yes. Well, at 2:20, we've arranged for every phone in the nation to go off to remind Bruce that it's time for questions. So we think that'll be an adequate reminder. Yeah, at 2:20, it'll vibrate even if you have it on silence. And hopefully his computer will not instantly switch to the broadcast. Okay. Well, we also want to welcome warmly those who are joining this class by Zoom. Special thanks to course coordinator technician Gloria Goodwin for supporting the hybrid modality. If you're interested in helping HASP become more environmentally friendly, you are invited to join other like-minded HASP members for an introductory exploratory session in the HASP classroom immediately following this course. As another reminder, we will welcome Holocaust survivor Tova Friedman to our monthly program next week on Tuesday, the 10th, at the Jack Miller Center for Musical Arts. Coffee, cookies, and conversation begins at 9, and the program begins at 9:30. Tova will be available immediately following the program to greet you and sign copies of her memoir, The Daughter of Auschwitz. You can purchase your own copies from the Hope College Bookstore, Reader's World, or from the HASP office, where a limited number of copies are available after class today. On the day before, on Monday the 9th, you can be introduced to Tova's story when we screen the documentary Surviving Auschwitz, written by HASP member Milt Newsma. This free screening at the Knickerbocker Theater will be followed by a panel featuring the film's director, the writer, and the producers. We hope that you can join us for both of these very interesting events. Now, for today, we are very privileged to have Bruce Eckert as our speaker. Bruce has a Bachelor of Mathematics from the University of Chicago and an MBA from Michigan State University. He also studied computer science here at Hope under former department chair and current HASP member, Herb Dersham. Bruce has about 30 years of experience in the healthcare IT field. He has held a number of positions, including the Chief Information Officer and IT Director at Holland Hospital, and also at Rest Haven. Excuse me, Pine Rest. Important distinction. Bruce is currently the Director of the KPMG Deal Advisory and Strategy Division, where he still focuses on healthcare IT. Please help me welcome my favorite intellectual, Bruce Eckert.
Thank you, Gary. I'll add one other thing to my credentials. My wife is a Hope graduate. So yeah, I live here in Holland, not too far away. I walked over. I can't say I'm a lifelong Hollander, but pretty close. I would have if I had that choice, if it was my choice. When we first moved to Holland, of course, in the 80s, people would always quiz you on, and I didn't have the Dutch credentials. But I'd tell people, oh, but my wife's grandparents live in Zealand. And everybody's like, oh, Zealand. Oh, yeah. So that worked pretty well. Okay, so I do want to give a quick introduction to my talk. I've put this together over several years. And I usually give it to healthcare IT audiences. So people who work in IT at hospitals and so forth. So that there is kind of an IT spin to it, but it's not really about IT. And I took out some of the, stronger IT content for this audience. It's really about healthcare in the US. So let me get started. You've already heard about me. Okay, so I have a number of data sources that I wanted to credit right up front. A really key one is the OECD. I don't know if I can get this to work, but the Organization for Economic Cooperation and Development. you're not familiar with it, it's an international group, 37 countries. It's sometimes called the Club of Rich Nations. But they publish a lot of healthcare statistics comparing health systems around the world. So it's really helpful for that reason. And the other countries in the group are, more or less kind of like us. So that's helpful too. But then there's a bunch of other sources and probably a few others I missed. Okay, so a really basic couple of facts about healthcare in the United States. First is, where do the dollars come from? And you might say, well, they come from us, and that's true. They always they come from the consumer, from people. But if you think about who is it that writes the check that pays the healthcare provider, pays the doctor, the hospital in the end, who is that? Well, there's a number of different kinds of payers, we call them. Commercial health insurance, about 30% of the dollars come through commercial insurance companies. That's the largest single chunk. Medicare is next, 21%, followed by Medicaid, about 17%. And then there's a bunch of others. But an interesting thing that many people outside of healthcare are not aware of, in fact, a lot of people who are in healthcare are not aware of, if you add up the government payment sources, state and federal government, it's now over 50% of their healthcare dollars flow through a government program. So Medicare, Medicaid, CHIP, the VA, military health. There's the federal government alone has over 80 health programs that go to help pay for healthcare. So the government is a major player in our healthcare world now. That happened. We crossed the 50% mark like in 2019, I think it was. Okay, so then where do the dollars go? Well, a couple of obvious ones: hospitals and doctors. There's together that's a little over half, almost 60%. Then there's some doctor-like services, dentists, other professionals, physical therapists, chiropractors, things like that. Adds up about 2/3. And then about half of what's left is long-term care, post-acute care of some sort. And then there's other stuff. Up at the top, you'll see two administration costs, and we'll talk about that later. So that is a part of what we'll be dealing with. So that's just kind of the basic landscape. The value chain. I don't have a slide for this, but if you think about the healthcare value chain, how does it work? Well, people, employers, and government put in dollars. Many of those dollars flow through either an insurance company or some sort of intermediate payer like Medicare or Medicaid. And then those go to the providers, the hospitals, doctors, chiropractors, pharmacies, etc. And then those entities buy products from pharmaceutical companies, medical device companies, all that sort of thing. So that's kind of how healthcare works. Okay, so I love this slide. This is the key one. I tell healthcare audiences that we should all make this the wallpaper on our phones for those of us who work in healthcare. So what this shows is the per capita cost of healthcare in a bunch of different countries around the world for 2020. And you can see there's one incredible outlier here, and that's us. We're way above average. In fact, the total cost of healthcare per person in the United States is almost 3 times what it is for the average of all the other countries in the OECD. We're double what Canada is. We're almost double second place. So this is a problem. And I got to give this talk in Houston once. And so that's why I titled it this. And I told them there, I said, I've been waiting for years to be able to do that. So I've just left it. Okay, now here's another view of it. But this is healthcare spending as a percentage of GDP. So instead of looking at it in terms of hard dollars, it's like how much of our economy is devoted to healthcare. And it also gives a time series view of it. So again, you can see we're way at the top. We're spending way more than anybody else. We're approaching 20% of our economy is healthcare. Yes. Yes, it does, but that's a small, well, a certain portion of public health related research is in there, but it's a really small percentage of the total spending. Yeah. And you can see that, we've been above everybody else for quite a long time. But 20 years ago, no, 40 years ago, we were still in the hunt, down here, it's like, okay, we're a tiny bit higher than others, but not much. And now, there's virtually no contest, right? Everybody's gone up. Every country is dealing with rising healthcare costs. Even the fairly low cost countries, if you read any of the literature about healthcare, they're complaining about healthcare costs going up, but ours have just gone up a lot faster. Okay, so I hate to admit it, but I'm not the first person to notice this problem. So there's been lots of activity on what to do. How can we solve this? And you can see, lots of different people, parties have been involved. We'll find, I won't go through all these, but we'll find like the common person's view of it and what you hear in the media is for the most part wrong. What the payers and providers have been doing about it, which is basically to control utilization, is also wrong. The government has been very active in trying to control this. In fact, there's a law, the Affordable Care Act, right? That turns out doesn't do very much to actually control the cost of healthcare. But what it deals with is how it reallocates the cost, is really what it does for the most part. The Inflation Reduction Act, recent piece of legislation, does a little more, but still it's a lot more about, how is the cost shared rather than trying to reduce it. So here's a guy who had an idea, but I thought it was a pretty good idea. It's I hate to tell people this, but I remember this. I remember the presidential debate where he said this. So Ross Perot, 30 years ago, a little more than that, said, we've got the most expensive healthcare system in the world. It ranks behind 15 other nations when it comes to life expectancy and 22 other nations when it comes to infant mortality. So we don't have the best. Pretty simple, folks. If you're paying more and you don't have the best, if all else fails, go copy the people who have the best and spend less, right? Well, a couple of things have changed since Ross's time. So, we do have to recognize that. We're now behind 23 others in life expectancy and 31 others in infant mortality. So there have been some changes. So anyway, I think, if we as a society wanted to take Ross up on his proposal here, we probably ought to know something about those other health systems. How does it work elsewhere? So the economists, I'm not one, although I did, Gary and I were talking about this before. I did take 1 year of economics when I was at the University of Chicago. So could I claim to be a Chicago trained economist? Anyway, so the economists that study this say there's basically 4 kinds of health systems around the world. And here they are. So we'll go clockwise around them. So we'll start with single payer. This is what Canada has. And I think we have some, big familiarity with it. So in Canada, the healthcare industry, the provider part of the industry, the hospitals and doctors and so forth, are organized more or less like ours are. Mostly private entities. A lot of them are not for profit. But the payer side, there's really not a payer side. There's one payer, and it's the government. It's technically the provinces, but that's basically it. So the insurance side of it doesn't really exist. The next one is the Bismarck plan, and this is what most Western European countries have, and a few other countries like Japan uses the Bismarck plan. And the key things about the Bismarck plan is, first off, the provider side of the industry is, again, more or less like ours. And the payer side is too. They have private insurance companies that handle most of the healthcare for people. But the key features of it are, 1, there's an individual mandate. 2, there's an employer mandate. And 3, there's government subsidies to make it affordable for the individuals and the employers. Next is the National Health Service. which is the UK's system, basically. This one is pretty different. So in the UK, the government owns or controls the provider side of the industry. Hospitals are mostly government entities of some sort. And physicians, they work for the government. And there is no payer at all, really, because healthcare is provided sort of like public education is here. You just get it if you're, a citizen. And then last is cash or fee for service. And here, how healthcare works is I compare it to dry cleaning. You ask for a service, you get it, and you pay for it. And that's it, cash, basically. Very popular in the less developed countries of the world. So, now you might be thinking at this point, as I was talking about that, gee, I wonder which one ours is. Well, we have all of them. So if all of them sounded a little familiar, that was why. So, and this is part of the problem. So we have single payer. Medicare is a single payer plan, or used to be anyway. Bismarck program probably sounded really familiar, didn't it? The Affordable Care Act is a Bismarck plan, and that was the goal, is to convert our health system into more of a Western European Bismarck style organization. National Health Service, we have some of that too. The Veterans Health Administration works like a national health service, and so does the Indian Health Service, and there are a couple of others. And then cash and fee for service, I think we're all familiar with that too, right? So we have them all. Now, this slide, I really like this slide, but it kind of, I often have a little trouble getting across the power of what this is saying. But, sometimes I've had people say, well, okay, we spend more for healthcare, so what? It employs a lot of people, we can afford it. What's the problem? Well, sorry. Okay, economists, the features of the way our health system works, economists would call it we would say that we have a deadweight loss. We're paying for something that's not delivering value, or not equivalent value. And I wanted to just show this to you, and I'm going to key in on one thing here. Okay, I'm comparing us to Canada. Our healthcare cost is about $12,500 a year per person. Canada, $5,900. Now, in Canada, as you know, the government pays a much bigger share of healthcare than the United States does. Even though we're at 50% now, they're at 75 and going up. But because the government's share, the dollars that the government spends in Canada per person are actually less than we spend, because a higher percentage of a lower dollar amount ends up being a lower dollar amount. In fact, the Canadian government spends a lower percentage of their overall budget on healthcare than the United States does. And this one I think is the real kicker. If it were possible for us to convert to Canada's plan, like right now, magic wand, boom, we have it with all of its features and flaws, and just exactly like Canada, our federal government would save $625 billion a year. That's almost the entire federal budget deficit. So I think there would be some benefit if we could solve this problem. And, and I'm going to compare us to Canada a lot here, but I just want to say, I'm not proposing that the Canadian system is the way we need to go. That's not really what this is about. Because the problem is not, we'll see, the problem is not so much the system that we have, but the cost. There are other countries with other health systems have the cost under control, and they're able to manage it. Okay, so in thinking about this, I thought there's only 3 reasons that our costs could be so much higher. One is that we use more healthcare, right? If we buy more, if we buy twice as many units of service of healthcare, it's gonna cost us more. Another is that ours is better, and it's worth the extra cost because we're getting it's much better. We're getting better services and results. And the third is it's inefficient. We're just not very good at it. So I thought, okay, it has to be one of these three, or maybe a combination of these three. So let's take a look. Let's kind of, as the physicians often do, let's try to rule some out. Okay, so do Americans use more healthcare? What do you think? How many for more? Okay, how many for less? How many for about the same as everybody else? Okay, it's pretty evenly mixed. Okay, well, let's start with physician visits. So OECD countries, the average citizen of an OECD country sees their doctor almost 7 times a year, or a doctor. Americans, 4. Canadians, they're just about at the average. They're about 6.5. But one that I always like to mention is this kind of mauve colored bar way out at the left. That's South Korea. 17 times a year. It's every 3 weeks. The average citizen every 3 weeks, you know. Now I know, some of us as we're getting older, we go more and more often, right? But can you imagine like a 25-year-old seeing their doctor every 3 weeks? But anyway, so that's doctors. Okay, hospitals. And I do hospitals in 3 parts. So discharges, just how often is somebody hospitalized in different countries? Well, the average, and the numbers, population adjusted and all that. So the number itself doesn't really have that much meaning. But as you can see, the United States and Canada are both well below the OECD average. So in both of our countries, we're admitted to the hospital less often than in other places. But if any of you have worked in healthcare, especially a hospital, you're thinking, wow, hospital admission, there's a huge difference in them. And that's true. So let's look at average length of stay. How long do people stay in the hospital once they're admitted? And the average is about 8 days. Canada's about average. We're below that. We're at about 6. And this is something, having worked in the healthcare industry pretty much my whole career, this is something that the industry has worked on for a long time, trying to keep that length of stay down in order to try to control costs. So, if you do the mental math on it, we go to the hospital less often. When we go there, we stay less time. We're using less hospital services. Yes.
Do we know the division here between, because part of our problem for poor people is they don't really have access to health care.
Yeah. Yeah, access is a problem. And I will address that lightly here. But I think that feeds into the utilization issue. I mean, you're already kind of seeing the story here. We're not using enough healthcare services, especially early in life. And because of our patient access problem, that is that people who don't have access to healthcare, that's exacerbated in that way. Now it's gotten a lot better in the last decade or so. The Affordable Care Act has really helped with that a lot, and a lot of health systems have done a lot of work on it. In fact, one of the things my company does, KPMG, we have a service that we go in and help hospitals figure out how to improve their patient access to get more people through the system. So it is something that's being worked on. But yes, it is a part of the problem. I wanted to mention surgeries also. That well, pause a second though. Somebody mentioned they can't read the bottom slide. I can send a PDF of these slides to anybody who wants them, or to Ian and have him distribute them. So you can look at them later. Okay, surgeries. I think, the person on the street's going to say, oh, people get operated on all the time in the United States. Surgeons just want to cut. Well, compared to the rest of the world, no, we're operated on about half as often as other people in other countries, and quite a bit less than those in Canada. So again, surgery tends to drive the intensity of a hospital stay, no matter how long it is. So the fact that we're doing less surgeries, we're in the hospital less often, we stay there less time. We're using less hospital services. We're using less physician services. The two combined, that's 2/3 of healthcare. And this, I won't go into additional stats on this, but this just goes on and on, whatever you look at. With one exception, diagnostic imaging. We do a lot more X-rays, MRIs, CTs than other countries, except for Japan, whose healthcare costs are about 1/3 of ours. Okay, so I think we can rule out that Americans use more healthcare. I think it's almost obvious that we use less, but we can say, no, that's not it. It's not because we use more. Okay, is American healthcare better? I almost hate to do a straw poll on this. What do you think? How many think American healthcare is better than most others? A few? Okay, how many think it's worse? Okay, how many think it's about the same? Okay, again, a split jury here. Okay, well, let's start with Ross Perot's measures. Life expectancy. Where are we at? Oh, the average in the OECD is about 81 years. We're at about 78. And I'll make a note here. I'm using 2019, which I know is a few years old. Why do you think I'm doing that? Pre-COVID, exactly. What happened in 2021 and 22? Down for us. Everybody else was flat. And I think next time I do this, I'm going to update this and show that. But anyway, we're considerably behind the average, but we're behind Canada. They're a little above 82. Remember the mauve bar, South Korea? They're up there at almost 84. You know, maybe we should go to our doctors more often. Okay, and over time, the trend over time, what does that look like? Well, this graph, I couldn't really put all the countries on, so I sampled it. So there certainly are countries that were below us, you know, in the early years, and some still are. But you can see the trend here. Everybody's going up, including us, but they're going up faster. And again, our mauve country, South Korea, that's this one with the triangles on that heavy line. Look at that. I mean, it's just remarkable how over the last 20 years, they've improved in life expectancy. They're considered to have one of the best health systems in the world now. Okay. All right, let's go to Ross's other one, infant mortality. And this one is one that the healthcare experts often use as kind of a canary in the coal mine for how good is healthcare. Because there's a lot of factors that go into it. You know, it's the health of the mother before the pregnancy, the quality of the care received during the pregnancy, the quality of the care for the delivery and the postpartum care, the quality of the pediatric and even the access to pediatric care in the first year of life, and then social determinants of health, of course. Well, we're not doing that great. You know, I guess you could look at it and say it could be worse. But we're above average, which is bad in this case, that, you know, we have more infant mortality than the average OECD country. We have more than Canada, not a lot more, but some more. But the disparity in this, and you've probably read about this, there are segments of our population that infant mortality rates are at third world levels. Another one that I threw in is maternal mortality. So, you know, thankfully, this is something that you know was rampant with our great grandparents, massively declined since then. But you know, how are we doing here? Well, we're still above average, so we have more of this than most other developed countries. Canada's a little below average. The ones I like to mention are these four: Ireland, Lithuania, Luxembourg, and Slovenia. It looks like they're at 0. You look way out there. So I looked into it in a little more detail, like what's the deal? They actually had 0 maternal mortalities in 2020. So there's a lot of room for improvement here. Okay. Now this gets to some of the disparity question here. Again, I'm not the first one to look at this kind of stuff. This is a report that was put out by the National Research Council, which is part of the Institutes of Medicine, sort of a quasi-governmental agency. Put it out 10 years ago in 2013, and I think it's worth reading this summary. The United States spends much more money on healthcare than any other country, yet Americans die sooner and experience more illness than residents in many other countries. While the length of life has improved in the United States, other countries have gained life years even faster, and our relative standing in the world has fallen over the past half century. This report identifies a number of misconceptions about the causes of the nation's relatively poor health. The problem is not simply a matter of large insured population or even of social and economic disadvantage. It cannot be explained away by racial and ethnic diversity of the population. The report shows that even relatively well-off Americans who do not smoke and are not overweight may experience, and actually if you read the report, do experience inferior health in comparison to their counterparts in other wealthy countries. This report's available free as a PDF online. I could send it to you if you wanted to. I'll just tell you, there's not a lot of good news in this report. It's not really happy reading. But they did this point about relatively well-off Americans. They statistically compared upper middle class Americans with no or few risk factors to upper middle class citizens in the UK with the same level of health risk factors. People in the UK are healthier and live longer. Okay. I think I've made the point now. But again, in America, more people die from preventable and treatable diseases or conditions than in other countries. Yes, Tom.
Okay, you're saying that the well-off
Mm-hmm.
are better off everywhere else except here.
Mm-hmm.
Has anyone looked at why that is?
Well, this report does try that report does try to delve into that, and they find a number of causes, and some of them we'll touch on here as we plow ahead.
Are they all healthcare related, or is it also just
Mostly, yeah,
life?
yeah. No, they're mostly related to how healthcare is delivered here. Yeah. I mean, if you think, people will say things like, well, more Americans are overweight than in other countries. That's true. But we're not the only ones who have overweight people. Have any of you ever been to Germany or Mexico? It's like it's Canada. I mean, I keep comparing us to Canada because really, socially, we're so similar. And they have some of the same risks and issues we do, but yet they get better outcomes. Some of it is that the way we consume healthcare, and I already showed you, we don't consume enough, probably. We tend to consume it later in life. So there's less emphasis on prevention than there is on cure after the fact. And part of it is driven by our payment system. Because if you think about it this way, okay, many of us do or have gotten our healthcare insurance through our employers, right? On average, how long do people stay in a job? 5 years, roughly. How often do companies change their health insurance provider? 5 years. So that means the health insurance companies are looking at it that I as an individual, they may have me as a customer for 2.5 years. Do they have the economic benefit of? Is it worth it economically for them to invest in my preventive health? No, and they know that. They all have preventive programs, but it's almost kind of window dressing. Who does have the economic benefit to help us stay healthy is the government, because we all end up in Medicare. Yes.
We have a question online from Pat. According to the CDC, life expectancy has declined for both men and women over the past 2 years.
Yep.
Healthcare seems to have become politicized. Do you see a correlation?
I'll pass on that. I don't. I mean, there are political and policy implications of what I'm presenting here. I try to stay away from that. I will say, to solve this, we do need to make some policy changes. You know, we cannot, it's necessary but not sufficient to make policy changes. We can't fix it without some policy changes. But policy changes alone probably won't fix it either. And I gave that roundup of the different how health systems are organized in other countries, in part to kind of thwart the political question, in that other countries with other health systems other than single payer are successful. And you know, what is it that they're doing? You know, what is it that Germany does? What is it that Japan does? What is it that South Korea is single payer, so we can't count them. But you know, Japan, Germany, Switzerland, a lot of countries have health systems, you know, payment systems that are sort of kind of mostly like ours. How are they doing it? Anyway, I do have some thoughts on that, but we'll keep going here. Okay. I did want to point this out too. I mean, I'll be real quick about this. So there's another organization, the Commonwealth Fund here in the U.S. studies this, especially healthcare quality. And you know, if I've been making Canada look great in comparison to us, if you ignore the U.S. in this little chart, Canada is actually not very good compared to, you know, the UK, France, Japan, Australia, so on. The real leaders here. So anyway, I just wanted to point that out. There's a little disparity in cost and quality state by state. This is kind of mushy. This is not great data, but I thought you might be interested in seeing where Michigan is. So we're a little below in life expectancy, which I'm using as a proxy for healthcare quality. It's not a great proxy, but you know, it kind of is. And then cost, we're below average in cost too. Interestingly, the real outliers in life expectancy on the negative side are also high cost locations. You can see at least one of the real outperformers in life expectancy is in the low cost side. So cost and quality are not tied together. And I think a lot of you who have, you know, quality management backgrounds are probably well aware of that. Okay. So I think we can rule out that our healthcare is better. I will mention one area that we are better. And the Commonwealth Fund points this out too. If you look at sort of the science of medicine part, we're the best. You know, Johns Hopkins and, you know, Mayo Clinic and Cleveland Clinic and, you know, Northwestern and these places. People, you know, wealthy people from around the world fly here to be treated at these places because the science of medicine we've got down. Our researcher universities, we're not the only ones, but we produce a lot of medical discoveries. But how do we take that kind of knowledge and get it to, like, you know, where it matters for the average person? We're not very good at that. Okay, so I wanted to talk a little bit about delving into the problem. This is looking at the cost problem, not the quality problem. I will contend kind of, you know, this kind of a tenet of quality management is that they're the same problem. That if you have a cost problem, if you can solve your quality problem, you'll solve your cost problem. If you can solve your cost problem, you'll probably solve your quality problem as well. So this is kind of a mashup that I did. I found, you know, one would, I guess the introduction to this, one would think that it'd be easy to look at Canada and say, well, what is it that we're spending more on than they are, right? I mean, if you and I went to the grocery store together and you spent $200 and I spent $100, we could figure out why, right? You know, you've got a dog, so you're buying dog food. I don't, you know, you like brand names, I'm buying store brand, you know, all that kind of stuff. But it turns out it's really hard in healthcare to break it down like that. Some economists, a number of economists have tried. So I took those studies and mushed them together here into this. And what I did, so this bottom part, the big red box, that's the per capita cost of healthcare in Canada. And then on top of it, I layered the excess costs. So for example, here's one, nursing salary surplus, $293. That doesn't mean that we spend on average per person $293 on nursing services. We spend $293 more. Okay, so these are all excess costs. Well, starting at the bottom, there are a couple of pretty interesting ones here. Again, if you go and ask the average person on the street, why does American healthcare cost so much? They'll give you two things: malpractice and defensive medicine, right? And prescription drugs cost way more here than they do anywhere else, right? Well, malpractice and defensive medicine costs us on average $196 per person per year. So yes, it's a part of the problem. It's a really small part of the problem. It's not the problem. Couple up, excess pharmaceutical costs. Yes, we do pay more for pharmaceuticals. On average, $372 per person per year. So again, it's part of the problem. It's not a huge part of the problem. And there are a couple of reasons for that. First of all, overall, out of our healthcare dollars, pharmaceuticals are not a big percentage. It depends on how you measure, but between 10 and 20%. So, we'd have to be paying like 5 times as much as the rest of the world to make that the problem. And 90% of the drugs that we take in America are generics. So we're getting the world price on those. It's just the brand name things, the 10% that are brand name. So yes, it's a little bit of a problem. If you look at the top, there's 4 pretty big sized boxes here. Top one, and we'll talk about these in turn, excess provider administrative costs. And then you look 4 down, excess payer administrative costs. Excess capital investment, talk about that. And then unexplained difference. All the economists came up with an unexplained difference. So there's excess costs, we can't figure out what it is. But in reading their papers, they all said, well, we think it's even more administrative costs, but we just can't quite nail it down what it is. But if you assume that it is all administrative costs, and it's probably not, but it's probably mostly administrative costs, those 3 things together, provider administrative, payer administrative, and unexplained difference, 55% of the difference between us and Canada. So this is the guts of the problem is administrative costs in our healthcare system. Okay, going to talk briefly about the capital investment part. So what does capital investment do? Builds capacity, right? But it also builds cost. So an example I like to use is if the Holland Hospital buys a new MRI machine, that's going to cost some millions of dollars. I don't even anymore even know how much an MRI machine costs, but it costs millions of dollars. But they're going to need a place to put it. So they probably need to expand the building. Okay, now they need heat and lights and all that kind of stuff. They need somebody to clean that part of the building, or they need staff to run the MRI machine, or there's a maintenance contract that pay the manufacturer. So you invest in capital and you also raise your operating costs. And this happens a lot. And what happens is that we have built excess capacity into our healthcare system that costs us a lot of money. And I won't read all these numbers, but but one way of looking at it is hospital occupancy. US, it's about 70%. So on any given day, about 70% of our hospital beds are occupied. In Canada, it's about 90%. So overall, they have less capital invested into healthcare. They just use it more efficiently, more intensely. Now that does give rise to the much touted waiting lists in Canada. I haven't heard that much lately because we've got the same problem. How many of you tried to get an appointment with a specialist lately? Were you able to get one next week? No. I had a guy too who once said to me, he said, well, but here in America, my doctor says I need a CT scan. I can walk down the street, and this is in Missouri, down the street in St. Louis, and there's 10 places I can go and get it today. And I said to him, I don't know what health insurance plan you have, but that's not how mine works. So anyway, we've got some of the same problems, but overall, on a macro level, this capital investment is a real factor. And you can see it. If any of you had the pleasure of visiting a hospital in another country? A few, right? Did they have big glassed-in atriums with player pianos and cut flowers? No, no. We make our hospitals look like the JW Marriott or something like that, right? When it doesn't need to be. They could be Motel 6, right? And most of them are. In other countries, you see a hospital and you go, "Wow, that's a hospital." Ooh. But anyway, they work just fine. Okay, administrative costs. So let's talk about administrative costs. So the payer side administrative costs, I think we all intuitively understand this. If you send $1 to an insurance company, they're not going to turn around and on average spend that dollar directly on health care services. They've got some overhead that needs to be covered, right? So, they're processing the claims. That takes work and effort, costs money. They do things like, they send out your benefit card, they have a customer service line. They may have to maintain the physician network, they've got a CEO, they've got plush offices, all this stuff. So there's costs that come out of that dollar before they spend it on healthcare services. And I think that makes sense. And that's reasonable. We understand that. But how much is that? Well, in the US, it's approaching 10% on average. Is consumed by all that stuff instead of being spent on healthcare. In Canada, it's 3%. And remember, their total cost to healthcare is half of ours. So that 3% translates into like the equivalent of 1.5% here, So it's way less. Now, this percentage does vary depending on who the payer is in the United States. And as a general rule, and this is starting to break down, is government programs tend to be pretty low and commercial plans tend to be pretty high. And there are exceptions, like, workers' comp is the huge outlier here. It's a really small percentage, it's like 1% of the healthcare consumed. You can kind of understand that too, that there can be a lot of abuse in workers' comp, so there's a lot of oversight needed, that kind of thing. But if we look at others, and I'll point out Medicare. So, well, no, I'll point out the DoD, the military health system, and the VA, pretty low, more or less kind of Canadian-like in cost. But remember, government programs, there's really no payer involved. Medicare. Now, Medicare is approaching that 10% level. Why is that? It used to be Medicare was like 2 or 3%, and that was much touted. Well, in this graph, there's 3 colors that you can see. There's the light blue, that's the state government percentage of administrative costs. Then the green is federal, and then the dark blue is health insurance costs, commercial health insurance costs. Well, the Medicare bar has 2 colors, the green and the purple dark blue. The green is pretty small. Federal government share of administrative costs in Medicare, about 2%. And that's about what traditional Medicare is, the administrative overhead on traditional Medicare. But this blue, what are the commercial insurance and Medicare? Medicare Advantage. We've rapidly been moving Medicare, basically outsourcing it to commercial insurance companies. And what's happened? The administrative cost portion of it is skyrocketed. Same thing's happening in the Medicaid program and the CHIP program. So anyway, that's payer side administrative costs. Provider side. Now, this is one that might not be as obvious. Of course, providers have administrative overhead. And I think that's pretty clear. And I think we all understand that, just like any other company or organization. But what I noticed when I was working, I really realized this at Pine Rest, when I worked at Pine Rest, that there is a lot of administrative things that Pine Rest and other hospitals around the country do, that the only reason they do them is because the payers require it. So I'll give you a really great example from Pine Rest. So Pine Rest, among other things, has an inpatient psychiatric hospital. I think there's 5 inpatient units, if I'm counting them up right. We had, when I was there was a social worker assigned to each unit, full-time on that unit. And their job was to every day review the medical record, the chart for every patient who was on the floor, and then in turn, call the payer, the insurance company that was responsible for that patient, and give the insurance company an update. That was it. There was no medical value to that. There was nothing that person was doing that was impacting the care of the patient. It was just a review and report back to the insurance company. 5 FTEs of social worker. It's not a cheap labor class. But you start to dissect it in hospitals and elsewhere, and it goes on and on and on. There's a lot of this. So the American Hospital Association took a look at this and found that in hospitals, it's a little over 20% of their total costs are that kind of stuff, that you wouldn't have to do it, but for the payers requiring you to do it. And in the physician offices, it's even higher. It's this graph, this study said 25%. There was another organization that did this study on small physician offices, 1, 2, 3 doctor offices, and said it's 40% of their costs are just costs that the payers require them of them. So combined, it's about 1/3 of our healthcare dollars that go into this kind of thing. Okay. So how can we fix it? And I forgot to say something really important up front. And I'll tell the story behind it. So I was given this talk, and one of my colleagues at KPMG heard it, and he called me later and he said, that was really depressing. And I told him, well, I need to change something then, because it's supposed to be optimistic. And you're probably thinking now, where's the optimistic part? The optimistic part is that we can do something about it. And I mentioned I'm an IT person, so I usually speak to IT audiences. And my message here is, even you, application analyst in the basement office at the Holland Hospital, you can help. There's something you can do that's going to help this problem. You can't solve it alone. IT can't solve it alone. But we have a part that we can help fix. And that's what the rest of this is about. So it's not globally macro level fixing it, but it does touch on some key healthcare issues that I think will be important. So I'm going to skip the IT part, but I did want to point out that healthcare IT, first of all, IT in healthcare, it is an administrative cost. It's part of the problem, and it's been growing fast. So this graph, and I'll give you all the caveats on it. So this graph over here, it goes 2007 to 2015, which was a special time in history for healthcare IT. But this red line shows the growth in overall healthcare costs in America. These stacked bars are showing the growth in healthcare IT costs over that same time. And it's exponential compared to the growth of healthcare costs overall. When I was at the Holland Hospital, which was getting to be a while ago now, the average hospital spent about 3% of their budget on IT. We were a little below that, thrifty Hollanders, right? Now, the average hospital spends at least 5% on IT. I have one client whose name everybody would know. They're really big, really well known. They're spending 10% on IT instead of 2.5%, 3%. So, and then the payer side, the insurance companies, they spend a lot on IT. Question?
You can look up your
Yeah.
results.
Yeah.
And that is a terrible angst for people who are waiting and waiting to hear
Yep.
about a blood result.
Yep.
And now you're trying to call the doctor's office and don't get a response. So I think
Yep.
that's a great IT thing that the hospital has done.
Yes.
The patients.
Yes. In theory, IT, computerization should really advance things. And I love that too. I'll talk about that in a little, about portals in a little bit. And online scheduling for appointments. I love that, or, Spectrum texts me, I disclosed who I go to. Spectrum, Corwell will text me and, say, hey, you've got an appointment on Thursday, you just can text back, reschedule, and that part's great, right? Anyway, but overall, there have been studies on, so what has all this investment bought us in the healthcare system? And the answer is not much, not yet anyway. So there's this, I found this in an economics journal, points out that productivity growth in the United States has averaged 2.5% annually since the mid-90s. In medical care, over the same period, reported productivity growth is negative. So during the information revolution, where everybody's productivity is going up because of IT, healthcare, no, we're going backwards. Why? Now, was it IT's fault? No, but IT didn't solve that problem either. There's this one, death by 1,000 clicks, would be a lot more interesting to people who are in the healthcare field. It's about 3 years old. It's available online. You can Google it. It's a pretty good read. Down here, EHR satisfaction. So class research, they're pretty well known in healthcare, pretty well regarded. They found that a physician who's unhappy with the EHR is electronic health record, by the way. A physician that's unhappy with the EHR where they're practicing is 3 times more likely to quit than one that's happy with the EHR where they work. Now, here's the incredible part of it. I point this out to healthcare clients all the time. What's the cost of losing a physician from your organization? I used to say $1 million. I was wrong. The latest study, $2.5 million. So a physician over at Holland Hospital quits to go work at, I don't know, Methodist in Gary, Indiana. It's going to cost the Holland Hospital $2.5 million. So if IT could improve the EHR over at Holland Hospital, and I don't know if they're satisfied or not, it's been away for a long time. But let's say theirs was, not so great. If they could improve it so the doctors would be happy, and they saved, I don't know, 5 physician turnovers in 1 year, $12.5 million of savings. I mean, there's a lot of power here that isn't necessarily being harnessed. So I do talk in my normal talk, I do talk about some IT things that the IT department themselves should do just to reduce the cost of IT itself. And presumably improve quality. I won't go into these things because they're kind of, nitty-gritty IT stuff. But a lot of it is really management practices, not the technology they're using, not the skills and all that, but just some management practices. But to your point, and everybody in the industry, there is a lot of power here. You can do a lot of great things clinically and operationally with IT in healthcare. As it happened, my employer did a study. Actually, we did not do it. I need to be real clear about that. We paid for it. So KPMG paid for this, but it was done by a think tank in the UK called the Nuffield Trust. And if you want it, I can send you a PDF of it. There are some quotes from some KPMG partners in there, but they didn't really do anything. Nuffield Trust did everything, and then they gathered, you may know how that kind of thing works. Anyway, but they did a nice job of pointing out some areas that IT should focus on in order to get the value that IT can deliver and improve both quality and cost in healthcare. And they're not, for the most part, the really visible, jazzy, sexy things that healthcare IT people like to do. Funny how that works. It's kind of, rote kind of stuff. But this does touch on some problems in our healthcare system that need to be fixed in order to solve these problems. So I think I'll go through these. So decision support and standardized workflows. There's lots of examples of this, of just the ball getting dropped in healthcare. And a way to do it, there was a book that was popular a decade or so ago, the Checklist Manifesto. It was by a surgeon who just said, simple checklists can solve so many problems. It was a pretty good read. And we can do that with healthcare IT systems, provide checklists and reminders to, did you count the instruments, that kind of thing. And we're not universally doing it. There is an organization that is doing a great job of it, and that's Narayana Health, which I dare say none of you have ever heard of. That's because they're in India. although they recently opened a hospital in the Cayman Islands. Anyway, their quality is on par with European countries, and their costs are massively less. You say, oh, well, they're in India, labor's so much lower. Well, they use US trained board certified physicians, housekeeping staff, they pay them. But that's not really why the cost difference. It's the way that they practice medicine. And they use their computer system to push decision support all the time. It's always telling the caregiver what the next thing is to be done on that patient and do it now. And it works great. Okay, so that's one. Patient engagement and self-management, to your point. Okay, so some of this is getting a little old, but that's me in the upper left-hand corner. I had the unfortunate incident at the corner of Central and 8th Street about 6 years ago. I was crossing the street. I had the light, I was in the crosswalk, and a truck hit me. So now I broke several bones and things, but I healed pretty well. And this is me in the Holland Hospital. So it's only in one night. By the way, and especially for orthopedics, Holland Hospital is an excellent hospital. They're often rated very highly in the United States. Anyway, I got great care there. They, to a certain extent, followed the Narayana health model of like, what's the next thing to be done? So I remember the nurse noticed in my chart that I had not yet had a flu shot that year. It was in January. 3 a.m., she woke me up to give me the flu shot. But I, knowing kind of how healthcare works a little bit, I thought that was the right thing to do. That was kind of annoying, but it moved things along. Anyway, so there was a lot of home care involved, and so I had home health people coming to see me, and I kept track of two things: my medications and my physical therapy exercises. And here are my logs. There's my medication log, the handwritten one. The other one is my exercise log. And one of the caregivers told me, "Oh, this is great. You're keeping such great records." And I thought, no, this is terrible. Look at that. Why don't you have an app for me that I can just do it? It'd be easier for me. You could read it and you could look at it ahead of time. Well, you probably aren't going to look at it, but the analytics engines inside of your computer systems can analyze it and point out any errors. Like if I accidentally took 2 of my pain medications at one time, there could be an alert or something like that. So anyway, nobody does this yet. I went through, because I do what I do, while I was convalescing, I checked every one of my patient portals every day. And what did I find? A lot of inconsistencies, a lot of missing data. It was clear that this was not really great. I liked my insurance company, but it's like, no, we have no record of anything. And it's like, well, you've been writing checks. We know something's going on. Anyway, so this is an area that this study points out that we're not doing a great job of. That more than just looking up information, the patient there should be some interactive qualities where the patient can keep track of things themselves, can contribute data that helps better assess the overall health of a person. And it would be easy to do. It really would be. But nobody's doing that, not the big health system. This one's related, better coordinated care. So this is a problem, and I kind of pointed out with the portal exercise that the portals didn't have the right information between them. Because healthcare providers are not exchanging information with themselves the way they should. So this has been a big emphasis of the government, is to get electronic information flowing between healthcare providers, called HIE, Health Information Exchange. And they publish statistics on it. And what these graphs show in the upper left is that over the recent years, and this is a few years old, but they publish things a few years behind, physicians, their use of HIE has been declining. And even at best, it was only 50% that were doing anything in this area. The hospital side has been going, which is on the right-hand side over here, It's been going up over time, which is good. But the report points out that less than half of hospitals are doing all four things that they could be doing with it. So what does that mean? Well, a lot of my colleagues say, oh, well, that's terrible because now the clinicians don't have the information they need to properly take care of the patient. I think that's wrong. I think they do have the information they need. They're just getting it in inefficient ways. Yes.
The inefficiencies that's gone along, in my perspective, is in large part because the language of the information is different in the physician's office than the language of the information
Yeah.
used in the hospitals or in the surgery center, and it's just incompatible software.
Yeah.
So
Well,
what people end up doing is just sending a hard copy of whatever they've done.
Yeah.
And then if that needs to be then entered into the system, again, using staff and administrative time and
Yeah.
cost to do that.
Yeah, exactly. That's
and-
how it's done, the fax machine.
Right, and it adds to,
Yeah.
redundancies and so forth.
Mhm.
In a system where a physician's office and say a surgery center has the same system, the efficiencies brought up by information technology is incredible.
Yes,
Your chart can be everywhere at once.
Yeah.
Information, especially imaging information, can
Mhm.
be everywhere at once. I had the pleasure of being exposed to a system like that.
Mhm.
And when information tech
Mhm.
and patient records came
Mhm.
along for us, it was like, people were nervous. Very quickly, it became a tremendous tool.
And if any of you have any familiarity with this area, there's one vendor, Epic Systems, the dominant player in this field. And the reason that they were so successful is because they created their system to be one system for every environment, the same system. So hospital, physician, same thing. They're expanding the system into all kinds of other areas now, including payers. So they're really trying to cover the environment so that data standardization is there. Now, the electronic, the HIE, the tools that are used to do this, though, can solve that incompatibility issue, but they're just not being leveraged. In fact, Epic has a feature that everybody loves called Care Everywhere, Care Anywhere. Anyway, so your doctor, if you go to a doctor at Corewell, and they refer you to a specialist at, I don't know, the Cleveland Clinic, they both use Epic. They can get, they can see the other records, and people, oh, that's great. What they're doing behind the scenes, all Epic is doing is they are using the industry standard HIE tools to do that, but they're doing it all. That almost nobody else has enabled all the data elements to work that way. Anyway, kind of a lot on that. Proactive and targeted care. And you hear a lot about personalized medicine, genetics, so on and so forth. And yes, there is value in all that. It's expensive right now. But what's probably more immediate, and a lot of places are doing it, is using machine learning and artificial intelligence to do predictive analysis on patients, to identify what patients are at risk of. The first one that hospitals looked at is readmission, because they're penalized by the payers if a patient's readmitted within 30 days of a discharge. So they're looking at it like, well, okay, this person, we think they're ready for discharge, but are they at risk of being readmitted? And if they are, then we probably want to keep them a while. So anyway, all of that and lots of other things now are done using largely machine learning algorithms. So it is generative AI, not used too much in healthcare. There's a lot of skepticism about it, but the other piece, the machine learning part, is used a lot. Improved access to specialists. This is one that the Nuffield Trust study points out. There's huge gain if we can somehow get specialist care to people who need it in the time that they need it. So, we've all gotten used to telemedicine during the pandemic, and that's called provider to consumer. That's good, but there's not really a quality or cost benefit to it, for the healthcare system. But what they call provider to provider telemedicine, there is. So that's, behind the scenes, your provider consulting with a specialist, it's, some distance away or whatever. they're finding the payoff of that is really big. And it's becoming more and more common. There's a lot of small hospitals now will have ICU units that are remotely monitored by big health systems. And that's something that we're finding helps a huge amount. And then really a mundane one, resource management. Hospitals spend a lot of money on labor. You'd probably guess that. Turns out to be about 75% is either direct labor, people they employ, or services that are basically labor. Like, most hospitals outsource laundry, but that's still a labor kind of service. So this guy here, that's Willie Sutton. Do you guys know Willie Sutton's law? Why do you rob banks? Because that's where the money is. So if you're trying to reduce costs in healthcare, this is where the money is. It's in labor. How do you save labor? And what I've noticed, and my company has noticed, is hospitals especially are not doing a great job of leveraging the computer systems to help improve this. Yeah, they have employee schedules online. They do patient schedules online. Some marry the two together pretty well and try to, get denser schedules built and, more efficiency that way. But the area that there's starting to be a lot of work on, a lot to go. There's a phrase in hospitals called working at the top of your license. And the idea there is that a nurse should only do things that only a nurse can do. If there's a task involving patient care that an LPN or an RN, I'll say, if there's a task that an LPN or the aide can do, the LPN or the aide should do it because the RN time is more valuable. You should be focused on just the things that RN can do. So great idea. How do you know you're accomplishing it? Well, nobody does right now. And they don't have a way of monitoring it. They don't really have a way of diagnosing it. Until now, we are using the computer because the electronic health record system does record in it everything that's done to a patient in the hospital and who did it and when they did it. So you can mine that, and there are other systems too. You can start to mine that and find out, are you using your nurses most efficiently? And do you have the right mix of labor? So we're predicting there's a lot of savings involved there. And then, it's continuous cycles of learning and improvement. I won't say too much about this, but the places that have developed a culture of trying to leverage their information systems and working jointly with the operating areas and IT get a lot of bang out of it. And I had a client who told me a story recently that was great on this. And so a new CIO comes into this organization, and what he does is he disbands the IT department. So it's a big health system. IT is in an office building, some distance from the hospital. He changed that at least for some of the IT departments. He went to the nursing units and found, storage closets or some other unused space and parked the IT people there. Okay, you two are on 5 West and you two, over here on 6 North and all that kind of stuff. Astounding results. What happened? Well, the nurses and others were on the floor and you'd see the IT person was, oh, hey, if you've got a minute, I was wondering, could you do this, that, or the other thing? They said they found hundreds of little things that were easy for IT to fix, but they didn't know about it. And the nursing staff didn't have the opportunity, they weren't going to spend a half an hour calling the help desk or writing out a request slip or something like that. But one of them saved every nurse in the hospital almost an hour a day. And it took the IT person like a week to develop it. And it's so anyway, so this, getting the communities together is really powerful. Anyway, that's what I have. Summary, that is just this, what we're seeing, unfortunately, is that there's not a single silver bullet to solve this, that the improvements are going to be come from a large number of smaller changes. Except for policy changes. We do need to make some big policy changes. So we've got a few minutes for questions until the big event here. Does anyone have additional questions? Yes.
Do you want to wait for a microphone so our online people can hear the question?
Are hospitals spending enough money on IT?
Yes, they are. They're not deploying it. optimally, in my opinion. They need to focus on some of these more mundane things of getting things to work better together, rather than looking at even higher levels of automation in some of the clinical areas.
Bruce, I have a question.
Yes.
I have often heard it alleged that the reason American healthcare costs so much is simply that all of the members of the healthcare industry get paid a lot more than their European and Asian counterparts. Does your research support that, or do
Yeah.
you think that's not right?
There is some truth to that. So that graph, that bar chart I had with the big red block and all that, did have in there excess physician salaries and excess nursing salaries. And the two things together, that's about $800 a year per person. And part of that unexplained difference is probably other professions too, pharmacists, physical therapists, respiratory therapists, and so on. So we probably pay all those a little more than they do in other countries too. Altogether, it might be 20% of the difference. It's not, but it's there, and we're probably not going to solve that.
First question, does HIPAA affect this? Does it cause things go up, or is every country's whatever HIPAA equal?
Well, we do not have the tightest privacy regulations in the world anymore. So on healthcare, it does add some cost, but the core of HIPAA was actually designed to reduce costs, and it's something that you don't see as a behind the scenes, but it was to make electronic billing between the providers and the payers a lot more efficient. They realized to do that, they're going to have electronic information, flowing between entities. And then there's a privacy concern. That's where all the privacy stuff comes in that you see. So the core of HIPAA was designed to reduce costs, and it helped some, but it's not all the way there yet. It's had to have several revisions.
Second question, as we hit 2:20.
Yeah.
You mentioned the Epic system, which was Easy Care or Care Easier. How often does that not work?
I don't know. I mean, I hear great stories about how well it does work, and even have some personal anecdotes about that. But it should work most of the time. The other major EHR vendor, by the way, is a company called Cerner, CERNER. Oracle just bought them last year. Holland Hospital uses Oracle, or Oracle Cerner now it's called. And it's got some similarities. They're, I call them Coke and Pepsi. So
I'm just going to mention, I agree with you about the rating of Holland Hospital. My experiences there have been wonderful. The care, the atmosphere, even the food. I was there in 2020 before the vaccine, and I had COVID. They kept me there for 5 days. But in reference to our hospitals look like the Marriott, and in Europe, they look like Hotel 6.
Yeah.
Those of us who are very sensitive to light, sound, texture, etc.
Yeah.
Should I keep talking? Anyway, that is very important to the care to us. And I would much rather be in a hospital that looks like a Marriott than the Hotel 6. Their paintings, their furniture, their color, their lighting, everything. I could just go there and read a book.
Yeah.
I love it.
Everyone, just so you know, that was a test of the national system. There is no emergency. You don't need to worry. It's just a test on your phone. And unless you had disabled those, you were going to get the message regardless of whether you silenced your cell phone. So apologize for the interruption, Bruce. Just want to let you know everything is good.
Yep. Daryl.
Large corporations that are taking over hospitals and healthcare systems, are they adding value to the whole process, or is there just a significant cost increase because of their involvement?
Yeah, good question. I'll need to answer that one sensitively. A lot of those large companies are our clients. So yeah, one thing that's happening in healthcare is private equity firms are buying physician practices. Usually they get to 100 or so physicians that are a target for a private equity. And they can do good things. I mean, they are looking to extract value from that purchase. And oftentimes they're looking for ways to make them more efficient. But they also have a tendency to increase prices. And I could tell you how they do it, but anyway, it's a mixed bag. It's a mixed bag.
I have a
Yes.
question from online. Having nurses doing only tasks
Mhm.
only nurses can do is a mentality which interferes with nurses talking with patients, spotting skin breakdown when at least being nearby with bathing, that sort of thing. I know this isn't an IT issue, but I think still this is important to remember.
Yeah, and I should say, I'm not a clinician, so I'm not really a healthcare expert. I just pretend to be. Yeah, no, there's value in all that. But there was a study I came across that somebody did a time and motion study on nurses in some hospital and found like 52% of their time was spent going to get supplies, running to a supply closet, getting something, going back to the patient room. So the idea is look for the things that really are not value added for the nurse to do and see if we can adjust the labor mix. Yes.
Just a couple of comments.
Yeah.
Most people here probably traveled to Europe.
Mhm.
And it seems that most people there walk. They don't
Mhm.
watch a lot of TV.
Yeah.
They eat dinner later,
Yeah.
which I don't like, but anyway. Then you fly back to the US,
Uh-huh.
you land,
Yeah.
you get in the airport, everybody seems huge
Yeah.
compared to,
Yeah.
okay? That's just a comment.
Yeah.
Second comment. We were in London between flights once. And needed to go to ER because they wouldn't let us get on the next flight.
Yeah.
Not knowing whether we were fine or not.
Mhm.
So ambulance picked us up, took us to ER. We were there for 4 hours, did some testing, did some other things, and then sent us back. And before we left the hospital, I said, "So how do I pay for this?" They said,
Mhm.
"Oh, you're a guest in our country. Don't pay."
Yeah. Yeah.
I'm going on flight.
They don't even have a way for you to pay. Even if they wanted you to pay, they don't have a way of doing it. Yeah. There was a similar story I heard about Sweden, and I thought that this was actually quite touching. It was on NPR, and there was I don't remember what it was, but there's some childhood disease that Sweden turns out to be really good at treating. And it's hard to, almost nowhere else in the world are they successfully treating it. So, of course, there are families around the world that are flying their kids with this disease to Sweden, which has a fairly socialized health system. So, again, like that, people from out of the country rarely end up paying. So they interviewed a doctor about this, and he said, yes, this is a burden on our health system. But he said, we can help these people, and it's our moral obligation to do so. Yes.
Of those healthcare systems where where it's free to the patient,
Mhm.
how do they keep attract and hold the physicians who you would like to see and who best do their job and do the
Mhm.
best job with specialty care and things like that?
Yeah, and there are different techniques, but from what I've read, and again, this is an area I'm not no expert in, is that the quality of work life for the physicians tends to be better because they're not focused on volume and relative value units and running the business side of it and all that. They do they're salaried. I mean, that's Mayo Clinic touts that all the time. But that's how their physicians are compensated. They're given a fair salary, and so they aren't trying to like get another procedure out of you because it makes no difference to them. Anyway, it's more like that. But they've disentangled the incentives, I guess. And not every physician is going to want that, but a lot of them do. Yes.
Holland Hospital does use the Epic system. I find that's very good. My daughter's in Washington DC, is able to check some of my
Mhm.
health information
Mhm.
when necessary. And But I find that the one thing that's a bit of a challenge is that some of the specialists in this area
Yep.
aren't connected to that
Yep.
system, and it makes it.
Yep.
But those that are, they're looking at multiple encounters and so
Right.
forth. and
Right.
That's good.
Yeah, no, it is an increasing benefit. I'm not sure it's been totally leveraged, but it is a help. Back in the 90s, when I was at the Holland Hospital, we actually had physicians asking if they could get a terminal into our computer system in their office so that they could check things real time. We were, of course, thrilled to be able to do that. So, yes.
One more comment. Sorry, I just scrolled. Let's remember that a single payer system covering everyone would be the way to cut down this enormous administrative costs in American medicine.
Well, yes, single payer systems have a strong track record of reducing administrative costs, but I've mentioned many times that other countries with other systems are able to do it too. So, Germany I'll use as an example, their costs are less than Canada's, but they have this Bismarck plan. So they have private insurers, private providers, much like we do. What's the secret? The government has more heavily regulated it. So things like, second opinions, pre-authorization, credentialing of providers, the coding of the records, all that is much more standardized and takes a lot of the friction out of the whole system without having to go to a single payer system. But single payer systems do have a strong track record.
Bruce has a call that he has to get on at 2:30, so I think we have time for one more quick question, Daryl.
I was talking yesterday with a guy from Arizona who was telling me a lot of people around there go to Mexico to get dental work done.
Yes.
And he said they have top-notch equipment over there, and many of them are trained in the US, go to Mexico, and the price or cost is about half what it is here. Is that because of liability issues, or what's the reason?
There's a couple things. I mean, they do have some lower operating costs. So any staff that the dentist has is probably going to be lower cost, other things like that. But a big part of it is that there are physicians who've done this here, that just opt out of the whole insurance payment model. Just say, forget it. I'm not going to have a biller. I'm not going to bill insurance. If you want to come see me, my price is X for a visit, pay me cash. I'm not going to have a fancy computer system. I'm going to use QuickBooks. Anyway, they have one I read about was doing that, was charging $35 for a physician visit, and he was doing fine financially. And people said, gee, my copay is more than that, and he's like, yeah, well, but just think of all the things. The average physician in America has 4 support staff to handle all the administrative stuff behind them. And if you just cut that out, and that's a big thing that they're doing. It's like the price is $200, and pay it now. Yeah.
I think because of time, we have to cut off the questions, but please join me in thanking Bruce for this very insightful.
Well, thank you for inviting me. As you can tell, I enjoy giving this talk. So